Welcome to this presentation on Chapter 1 of the NABH Certification Standards for Stroke Centers. This chapter is titled Access, Assessment and Continuity of Care, or AAC for short. Over the next few minutes, we will explore how a stroke center can ensure timely, structured, and continuous care for patients, from the moment they arrive to the point of discharge. Let's begin by understanding the intent of this chapter. AAC lays the foundation for how stroke centers should manage the flow of patients. It ensures that the center clearly defines what services it provides and shares that information with the public transparently. Once the patient enters, the chapter outlines how they are to be registered, assessed, and managed. It mandates safe environments, competent staffing, and adequate diagnostic support. It's not just about treating the patient, it's about ensuring they receive the right care at the right time, and that continuity is maintained throughout their hospital journey. This chapter focuses on three essential areas. First, a standardized approach to care delivery, so every patient is treated based on clearly defined processes. Second, robust mechanisms for transferring patients to higher-level facilities, if needed, especially in cases where the center's services are limited. And third, ensuring safety and consistency across every stage of the patient's interaction with the stroke center, from access to treatment to discharge. The first standard, AAC.1, asks the stroke center to clearly define the scope of services it offers. These services should be designed based on the healthcare needs of the community. Importantly, the services, whether diagnostic or therapeutic, must be delivered by appropriately qualified staff, and they should not be hidden away in a file. They must be displayed prominently in areas accessible to patients and caregivers, so there is clarity on what the center can and cannot offer. AAC.2 focuses on how patients are registered and admitted into the system. Every center must have written guidance on how to register patients, whether they come through the emergency, OPD, or as referrals. This process must be consistent and well documented. Most importantly, each patient must receive a unique identification number during registration. This ID ensures their care can be tracked seamlessly throughout their stay in the hospital. AAC.3 deals with what happens when the center cannot handle a case, particularly when specialized or advanced care is needed. The center must have a proper referral mechanism, including written guidance for urgent or emergency transfers. They must maintain formal agreements or memorandums of understanding with higher-level centers that can provide neurosurgery or other advanced care. And no patient should be transferred without a proper treatment summary that includes their current condition and the interventions already done. A special note is made here for neurosurgical emergencies, such as large hemorrhagic strokes or those requiring urgent intervention. In such cases, a rapid response protocol must be activated. The stroke center must coordinate with a designated partner hospital and ensure that the patient is transferred quickly and safely. A detailed summary of the diagnosis and treatment provided must accompany the patient, ensuring continuity of care even after transfer. AAC.4 covers patient assessment. Every patient, whether seen in the OPD, emergency, or as an admitted case, must undergo an initial assessment based on clinical needs. This should be followed by periodic reassessments to monitor progress. All assessments must be documented accurately and signed by responsible staff. This ensures that clinical decisions are well informed and that there is accountability in every step of care. A key part of patient assessment is the development of a personalized care plan. Doctors and nurses must work together to document a plan that reflects the specific needs of the patient, as well as the concerns and expectations of the family. This care plan should be dynamic, incorporating inputs from all relevant disciplines: neurology, physiotherapy, speech therapy, nursing, and more. The goal is to ensure a holistic and well-documented approach to patient management. AAC.5 emphasizes the critical role of diagnostics in stroke care. Laboratory and imaging services, including CT and MRI, must be aligned with the scope of care provided by the center. This means that if you claim to be a stroke-ready center, you must have 24/7 access to essential diagnostics. Infrastructure and staffing must be adequate, and all services must comply with national regulations and standards. Time is brain, and stroke care is time-sensitive. The standards require that initial diagnostic tests be completed and interpreted within 15 minutes of being ordered. All critical imaging and lab tests should be available round the clock and performed in-house. There should be no dependence on outsourced services for crucial early stroke assessments. When a test reveals a critical result, such as a major infarct or electrolyte abnormality, it must be communicated immediately to the concerned clinical team. This step is vital to ensuring that timely action is taken and that patient safety is never compromised. All diagnostic equipment must undergo regular maintenance and calibration. This includes CT machines, MRI scanners, lab analyzers, and bedside monitors. A written schedule for equipment upkeep must be in place to ensure accuracy, safety, and legal compliance. AAC Point 6 shifts the focus to discharge planning. Discharge should not be a hurried decision at the last moment. It must be planned in advance, in consultation with the patient and their caregivers. The process should follow written protocols and culminate in the issue of a detailed discharge summary, which the patient must receive before leaving the hospital. Occasionally, patients may choose to leave the hospital against medical advice. In such cases, the center must follow a defined process, including written acknowledgement by the patient or family, and documentation of any risks explained to them. This ensures that medico-legal safeguards are in place. The discharge summary is not just a formality. It's a roadmap for post-discharge care. It must include the patient's name, ID number, diagnosis, investigations, treatment provided, procedures done, medication details, and follow-up instructions. Rehabilitation plans, dietary advice, and warning signs must also be clearly mentioned in language that is understandable to the patient and family. In the unfortunate event of a patient's death, a detailed case summary must be written. It should include a chronological account of the clinical course and clearly mention the final cause of death. This documentation is essential both from a clinical and a legal perspective. AAC ensures that the patient's journey through the stroke center is seamless. From the moment they arrive, each step, registration, assessment, treatment, and discharge, is guided by standard protocols. This consistency ensures both quality of care and patient safety. When these standards are implemented properly, the benefits are enormous. Patients are safer, complications are minimized, and the care they receive is more structured and predictable. It also ensures better documentation, making audits, reviews, and improvements easier for the hospital. To conclude, Chapter 1 of the NABH Stroke Center certification sets the foundation for access, assessment, and continuity of care. It asks stroke centers to define the services, standardize their processes, and ensure that every patient receives timely and appropriate care with full documentation and safety. When done well, this chapter transforms the stroke center into a place of healing, accountability, and excellence.